Good afternoon. Welcome to the Multi-Modal Imaging in CCSVI session on integrating imaging standards. Myself, Adnan Siddiqui, and Marian Simca will be moderating the session. Let's see if you can find seats and huddle up close. Since this is really a discussions session, we would like to start off with talking about consensus on an MRI protocol for CCSVI being presented by Raj Attariwala.
Thank you. All right, so we actually just had a close to 2-hour session, which was pretty animated on what we can establish for a MRI CCSVI protocol. So this is part of the slides that we actually had, so I'm just going to run through them quickly. So basically, we all know that MRI is still the most useful tool to assess the structure of the brain and for MS plaque burden. It's basically the de facto standard. I'm going to skip through all this part, and we're actually going to go with the goal of what our consensus was. Is basically what we want to do is get an MRI protocol for CCSVI, which can be easily implemented almost anywhere, something that's robust and will provide key information for the interventional radiologist and provide baseline follow-up for the neurologist as well. So what we came up with are two different sets of sequences. One are what we call the core sequences. So those are basically the sequences that can be used in almost any community radiology practice anywhere. So when a patient shows up and says, hey, I have MS and I want to see if I am eligible for treatment anywhere, what type of an MRI do I need? Then the next is some things that we went into that were optional, and then also probably the most important, considering more than 30,000 people have been treated, what the MRI follow-up recommendations are. So we'll start with this. This is actually the standard MS protocol that's been established by Simon, AJNR 2010. This is actually for both the head and the C-spine, and it actually goes through these conventional sequences, which are the basis that all the diagnostic imaging centers worldwide are using for their MS patients. So these are the starting point that we're actually going to use and incorporate into our MRI imaging, because this is what the clinical radiologists, this is what the neurologists are used to starting with as their starting point. And to this, we're actually going to add what we call the core sequences, which are sequences that can be integrated into this that will become key to diagnosing, or at least getting the community radiologists out there at least looking at and starting to understand what CCSVI may be. So basically the first one that we actually agreed upon to actually have part of the core sequences would be, in addition to those, including flow quantification. The agreement was to actually have it at 2 sites, one being C6-7, the other site being C2-3. So there are 2 areas where the technologist can basically, when they do their scanogram, we want to be above the facial vein, but they're not going to be looking for the facial vein. So if you give them 2 levels, one being C6-7, the other being C2-3, they can actually then go and incorporate into it. We also decided that the velocity encoding, or the VENC value, would be 50. So you can actually set the VENC for 50, and we'd be able to then incorporate flow quantification into a conventional MRI sequence. So that was one of the core criteria that were included. We decided that there would not be any complete terms on how to interpret the flow quantification. We would not give any guidance on what to look for in terms of the shape of what's happening with the flow versus time curve, or we were not going to incorporate any fixed number in terms of amount of milliliters per minute of blood flow. We figured that would not be included in the report. That would not be something that would be useful to the community radiologist. So then we actually went into the next area that was going to be important. That would be the gadolinium-enhanced MR angio and venography. So basically what we were going to be doing is actually doing the arterial phase injection, then the arterial and venous phase with a subtraction. And when we get to that, we're actually going to get the images which are here on this side of the screen. Here's the arterial phase, to which the community radiologist is pretty comfortable looking at that. Oops. This is a pretty standard set of images that all the community radiologists know what to do with. The MRV, on the other hand, is something that most radiologists do not look at, have never looked at, and are not really interested in. But it's something that we need to at least start to get them out there to recognize. And to that, the question is, what type of a thing should they be looking for? What we decided is probably the most important are going to be amount of collateralization. We know that the average person out there has at least one level of collateral, or one collateral. There are typically up to 7 that are seen in the MS community. So we're actually going to put together almost a checklist of naming the vessels. Here are, if you have more than 3 vessels, here are the names of them. Put those in your report so that it tells those who are interested, such as an interventional radiologist, that indeed we can see collateralization. That's one of the benefits of MR. And so it was decided that for the core sequence, because incorporated into the Simon criteria for MS, gadolinium-enhanced study is in there, so we would actually provide that as well with this MRV, which would be gadolinium-enhanced because sometimes these collaterals are not as well seen on time of flight, depending on the type of machine and variability out there. But the MR angiogram with subtraction is actually ubiquitous and can be done almost anywhere. Plus, it can actually be integrated quite easily into the criteria by Simon because there's a blank of 5 minutes that can be used to try and minimize the overall time of an examination. The community radiologist out there does not want a 90-minute scan. They basically want to take what they have and have an abbreviated quick scan. And that's what the guidance we're going to provide for them. Other areas, we decided to look at time of flight. It was agreed that the azygous vein will be not recommended to be assessed for by MRI. It was felt that it should not be included in. There's too much variability, so it is not recommended to do a time of flight or any imaging in the core criteria for the azygous. The research facilities can do whatever they want with it, but the community radiologist, no azygous time of flight, not recommended. Susceptibility weighted imaging for the core criteria for the community radiologist was decided to be optional. It's not part of the core criteria. It can be for research facilities. Same with perfusion weighted. That's also going to be part of the optional criteria, not core for the community radiologist. Diffusion weighted imaging was decided that it would be optional as well if clinically indicated. If there's worries that the patient may be at increased risk of stroke or something like that, it can be included as clinically indicated, but it is not part of the core criteria. So basically, these are all the criteria that we went through when we talked about them. And you can see that the flow quantification takes approximately 2 minutes per site based on the current FDA, Health Canada, European Union approved criteria. There are research protocols which are much faster, but they are, again, research protocols. They are not something that your community radiologist will have licensed on their machine, whereas the standard flow quantification will be. It's actually used in other areas, particularly cardiac imaging. We also decided that the MR angiogram, the MR with GAD, can be done in approximately 3 minutes. There's a window where it can be incorporated into the standard Simon MS criteria. So the goal was to actually try and minimize the amount of time that the core criteria would use. Time of flight for the azygous was excluded. It is not recommended to be utilized. We don't feel that MRI provides enough information from a community setting to be useful for treatment in terms of answering the simple question, if the patient in question has MS, do they have CCSVI, can they be treated? It was felt that azygous is not recommended to be in there. We just do not get good enough imaging to include it. Susceptibility, perfusion-weighted imaging, diffusion-weighted imaging, they're all optional. They are not included in the core criteria. So here again, this is the key sequences that's provided for all MS patients. This is provided by Simon, AJNR 2010, and the 2005 criteria. So we agreed that this must be included as modified by the site that the patient is getting. This is the standard criteria used for all diagnostic MS, not CCSVI, diagnostic MS. This is the baseline which must be incorporated. If we actually go and look in here, there's a period of time where the gadolinium is being injected, which is a 5-minute gap. The patient's laying on the table, there's an injection of gadolinium, they sit, they wait for 5 minutes. During that period of time, we can actually go and incorporate the MRV and an MRA. That buys us time. So effectively, in our core criteria, all we have actually added is whatever 38 minutes, this includes a C-spine, we've incorporated an extra 4 minutes into the scan of a conventional MS exam. So we wanted to keep the core criteria short as possible so that it can actually be widely disseminated, so that it can be used more appropriately, and more importantly, it can actually become comfortable for the community radiologist to understand what an MRV looks like. It can also be then used for the community radiologist to understand what flow quantification looks like, because it is not widely used anywhere beyond the ISNBD people. So other areas that we were important to look at were follow-up post-treatment. There's been more than 30,000 people have been treated. Where does MRI fit in this? The idea was, here are the possible intervals that we could look at. When should people be coming to return for a follow-up MRI? It was agreed that basically at 1 year's time post-treatment, a gadolinium-enhanced core MRI should be performed to assess the patient's change at that time. And obviously, if there or basically for follow-up standard treatment. If there are any change in symptoms, that typically will result in an MRI, but that can be ordered separately. But as a follow-up to treatment, it was recommended that a 12-month MRI core study be performed. And that's what we came up with so far. What we'll be doing is putting this together and submitting it to those in the group, and we'll actually have an idea of what's going on. I guess lights are out. Thank you.
Any comments, questions?
Okay, so let's move to the next step, please. Salvatore Sclafani. So in the morning we've discussed a lot about venography and related issues, and now results of our discussion will be presented.
We had a small group of approximately 10 people from Europe and the United States. I don't believe there was anybody from any other locations at the meeting. It was a mixture of clinical practice, academic practice, and we began by reviewing a survey. Perhaps for the next meeting we'll have that available. It's a little bit too long for this period of time. What we found is that we had very little consensus and very little evidence on which to base consensus about standards of practice in interventional radiology at the current time. We began by discussing what would be our indications for the procedure, invasive procedure, and our consensus was that it would be based on local practice. It could include MR, ultrasound, combination of both procedures, but those criteria we were going to await the recommendations of our colleagues who were speaking about ultrasound and MR. But local practice will make a difference. There were some opinions questioning whether there was a need for any imaging prior to performing a procedure based on clinical indications alone, but we had no consensus on that. We had no consensus on preoperative assessment by laboratory, etc. And we need to work on that, but there really isn't anything particularly different about those parameters in treating this disease as opposed to others. We had near consensus on the use of ultrasound as a valuable tool in the procedure room for access to the puncture sites and to assess the degree of treatment outcomes, but that there was no data on this subject in the literature to speak of, so we couldn't make consensus on that. We did agree that femoral access was the most rational approach to this procedure, and a very small number of people advocated for saphenous vein puncture, but there was overwhelming consensus that the femoral vein would be the appropriate access, and the majority believed that the right femoral access was the preferred access. But that would depend on local practice as well, and it also would depend on the veins that one interrogated. We had no consensus. We had some consensus on the veins to be interrogated by venography. Everyone agreed that the femoral, that the internal jugular veins and the azygos vein should be imaged, but there was not consensus on the iliac vein for May-Turner syndrome, the left renal vein for Nutcracker syndrome, or for imaging of the ascending lumbar vein. There was no consensus on brachiocephalic vein, no subclavian vein, or vertebral veins. The majority of people did not use intravascular ultrasound as a secondary procedure, but the people that used it expressed enthusiasm for its application in the management of this particular disease. We essentially did not reach consensus on whether it was mandatory to use power injection or hand injection, and we came up with a conclusion that whatever method was used, it would have to opacify the entire jugular vein from the jugular bulb at the skull base to the confluence with the subclavian vein. And we did not reach consensus about the density of the contrast agent necessary. There were some people who used very dense contrast and others used dilute contrast. And there were pros and cons for both, and we haven't reached consensus because there's no evidence on what we're even looking for at this point. What else did we get to the end of? We even had difficulty agreeing on what constituted a significant lesion. And there was no need for consensus about what constituted a percentage of stenosis, because percentage of stenosis is an arbitrary decision. Most people have used the measures agreed upon for arterial disease, which is 50% stenosis. However, we believed that we needed advice and counsel and evidence in fluid dynamics to know what constituted significant stenosis in terms of a vein, which is highly compliant structure. We agreed to come to an arbitrary decision about how to measure a stenosis. That we took 20 minutes. Because these are, vein is much more difficult to assess than an artery, which is fairly uniform, and we have pretty good consensus about. But vein is really no consensus. So we pretty much stopped there. We hadn't. That's our first meeting. A 50-question survey had been sent out to 82 physicians who practice interventional radiology for CCSVI. We reviewed those, and we'll incorporate that in the future. Our next idea is to take what we've gotten to consensus on, as well as to consolidate the questionnaire and come back and repeat the questionnaire with a lot more detail to the areas where there was no consensus, to try to understand the logic by which no consensus among 82 people was reached by any stretch of the imagination. There was no consensus in the 82 person survey about preoperative anticoagulation, postoperative anticoagulation, the indications for balloon angioplasty. So these are things that need to be worked out. And I think much of the questions are left without consensus because there is no evidence. And that's where we are.
Let's do it. Does it work? Okay, so you see that regarding gold standard, venography actually is not gold at all. So a lot of work should be done in the future. And now at least we know that we know actually nothing.
So given that you know nothing, if people have questions, they should come up and stand at the mic, so it's obvious to the moderators who has a question. I don't know, if I were an MS patient, I would then ask you, if you can't reach any consensus, at least are all the methods that you're applying safe? That would be one of my questions. And the second one would be, when you say you can't reach a consensus with 82 people in terms of how you're delivering the balloons or the pressures or whatever, do you at least have some guidelines that you can supply for that?
I would say that it would be inappropriate at this point, because we are using standards that are for different types of pathology, and we're learning why people do things. So that there's just not a lot of literature on the procedure itself, and there's not enough dialogue about, you know, what constitutes an appropriate balloon. There were people who used non-compliant balloons. The majority use high-pressure balloons, but there was a significant minority that don't. There were people that don't wash their hands before the procedure. We have a lot of work to do on this piece, because, you know, these are operator-dependent procedures. It's not like we can say, you know, you do a time of flight sequence in 3 minutes. You know, it could take 45 minutes to catheterize a single vessel. I think the evidence is there that it's a safe procedure done by different methodologies that have been done in different people, but I don't think we can say that any individual way is optimized, and that's why we didn't reach consensus yet. But, you know, to try to reach consensus in an hour and a half first initial meeting, it's really not, shouldn't have been expected.
I'm feeling better about being a neurologist right now. What about stents? I mean, I think some things have to be...
Well, you know, you're asking us to, you know, an hour and a half to review the entire procedure. Just couldn't happen. It's not like we didn't reach consensus on it. We just didn't get to it. The 82-person was an electronic survey, and the majority of people do not recommend stents. The only near consensus among the larger group, which weren't here, by the way, I just want to remind you, weren't here. This is a survey, you know. But the only thing that there was general agreement upon is that stents were used as a bailout procedure in case there was a significant complication during angioplasty. But there was no agreement. In essence, there was consensus not to use a lot of stents. But there were, you know, 12% believed that it was appropriate to put a stent in if you did angioplasty and the vein didn't open up properly. But we haven't defined what a proper opening to the valve, you know, to the vein is, so that becomes challenging. There were more people that believed that stenting was appropriate after repeated failure or recurrent stenosis. But we didn't get through it all. You know, it wasn't like this is only the first time we've had this discussion among the ISNVD. Some of the issues that need to be done are already being done by other groups, and we are going to await, you know, them to be published. The Society of Interventional Radiology has a large guideline coming out on standards for reporting in the literature. So until we get that kind of standardization, you know, it's going to be very hard to know what percentage stenosis is appropriate, if at all appropriate, whether you could even agree that percentage stenosis is a significant, you know, is it 10% stenosis? I think we need advice from people who, you know, can do that. I mean, it's what we do in arteries, not what we do in veins. We don't think that we have the right tools yet. That's what I'm saying. But on an eyeball judgment by experienced interventional radiologists, the procedure is safe, but we do it different ways. We're trying to get to a consensus about the right way to do it, that's all.
Yeah, I think, let me sort of reiterate on what Dave is pointing out. The one thing we do know for the people who have published their data and have reported on their data is that this is a safe procedure. There is a lot of variability in terms of how you do the procedure. Now, I understand, for instance, not all interventional radiologists do a full scrub before they down their gowns and gloves to do an interventional procedure. That's fairly standard. That's true for the 200,000 cardiac caths that are done in the United States each year. So it doesn't mean that, you know, you're handling wires and catheters with your bare hands. So as far as standards are concerned, I think it's hard to define standards when the field is still in its nascent sort of phase where you're still collecting data. I think the biggest problem we deal with or we're facing is that not enough people who are doing this are collecting their data, even the simple form of a registry. Well, what did you particularly do for your last 50 patients or 100 patients? It'd be great if, you know, at this forum we could have all the interventionalists who have done more than 100 cases come present their particular series of exactly how they did the 100 cases, what balloons they used, what was their anticoagulation, all the questions that Sal put together that circulated to all these people, if we had them. So right now we're stuck with the core group of people, like Marion here and Sal, who have really talked about their specific experience and how they have done, and now they come into a room where they're trying to gather consensus and they realize, well, people are doing it 20 different ways. I mean, there may be 20 right ways of doing this,
Right.
but I think it's hard to report on standards. So Dave, it's not dangerous, it's just people are still figuring things out. Sandy?
A question for Raj. A different question. I'm going to go to MR for a minute. Do you think there's any chance that the CAR would adopt the indications that you've got? If they would adopt that as a standard for doing the MRI assessment of patients with MS, you would collect some pretty good data pretty quickly in both the arterial and venous phase. And then it comes down to how would you collect the data. I mean, if you'll get them to accept that as a guideline, that would be phenomenal because you'll collect a lot of data very quickly.
Sure, so. Let's see, does this one work? Okay. So, sure, so the CAR, the Canadian Association of Radiologists, will they accept what we have as a guideline? Well, hard to say, but basically what we wanted to do is establish that core protocol. And so that core protocol is something that can be easily implemented into the standard MS procedure that's done everywhere. Every facility typically goes and takes that MS protocol and modifies it to what their neurologist is used to. We all know that what happens is the radiologist runs the machine and gives an interpretation. Then the neurologist goes and takes the images and looks at them and decides what they're going to do almost independently of the radiologist report. That's practical reality. So what we wanted to do is actually get people at least looking at the veins. We know that in the community, nobody ever cares about the jugular veins. All we know, at least in the basic teaching, is that there's typically a right-sided dominant, about 55%. Who cares? We normally never look at them. So the goal with what we wanted to do is say, with this MRV, with a gadolinium-enhanced MRV, you have a 5-minute window where there's nothing happening. The patient's laying there on the table before they get their T1 post-contrast MR. So during that period of time, you can actually go and image the neck and actually be able to incorporate that in without a loss of time. That's the key because, as you know, particularly in Canada, MR access is a big issue. MR time of studies is a really big issue. So we want to keep it minimum to provide information about the MRV, so radiologists are used to looking at it, and then also adding flow quantification, because again, for example, in Vancouver in the past 5 years, only 2 flow quantifications have been done at the second largest hospital in the country. So nobody is used to phase contrast MR. So if we at least put it in there, the hope is that people will start to incorporate it. Will it become implemented by the CAR for CCSVI? We don't know, but at least now we have something that we can all at least have agreed upon provides the core for what needs to be looked at for MS patients. Now the other bigger question is, can these set of sequences be actually used for imaging anybody who has a gadolinium-enhanced brain? Indeed they can. So at a cost of what looks like about 4 minutes of scan time, you can actually now implement this protocol widely. And that may be the most beneficial thing for CCSVI in the fact that right now we don't have much information in terms of what we are looking at beyond increased number of collaterals. The question is, what is normal? We don't know what normal is in the jugular veins or in any of the veins that drain the neck. But by establishing a protocol that can be easily implemented at a cost of only 4 minutes of scan time, we can actually start to find what is normal, because now we can take this same protocol, apply it to our brain cancer patients. We can apply it to our infection patients where we're actually doing an MR brain looking for any type of lesion. So that's the goal. Will the CAR adopt it? I have no idea. But our goal is to make something simple and clear that can be easily implemented relatively rapidly. So if you actually look at our protocol that we've established for the core, it basically takes things out of the research arm and says, okay, for those patients who are interested in CCSVI or actually just want for those radiologists in those MR facilities across the country in Canada or anywhere that are using MR, here is a standard protocol that can be easily implemented. That was the goal, number one. And the second goal is to provide at least some kind of guidance for follow-up with MRI. And for that, we actually piggybacked right on top of the standard MS follow-up guidelines, using, again, the 2 extra sequences of an MRV and 2 levels of flow quantification. We tried to keep it as simple as possible, and we got consensus on that. So we'll have to see what happens with time.
Next, we have Nicholas Liassis to talk about ultrasound.
So in the next room, I think we were much more lucky. We had a very fruitful conversation and very significant questions and discussions. And finally, the conclusion is that we have to have an absolutely standard protocol in ultrasound using standard criteria, and all of us, we have to follow the same protocol. Okay. The first annual meeting, it was in Bologna, and criteria which proposed by Professor Zamponi revised, and now we have new criteria. The only problem, as you know, with ultrasound is the operator dependent subjectivity. So two different examiners maybe can get a completely different opinion from the same subject. On the left side, you can see the original criteria, and this is the consensus criteria. We had long discussions about this. There are 8 papers in which we can see the prevalence of every criterion, and the most common criteria were number 1, number 2, and number 3. In November in 2011, there was a very significant paper by Professor Zivadinov, and in this paper you can see that the most significant criteria, it was number 3 and number 1. So I skip these slides. Just a very short, brief review about chronic venous disease of the lower extremities, which is a result of venous hypertension caused by reflux or obstruction. Actually, valve insufficiency are considered the biggest, the most significant pathophysiology and cause this venous hypertension with a dramatic increase in like this in the skin of the lower of the legs. So venous dysfunction develops when venous return is impaired for any reason and can arise from abnormalities within the deep veins, superficial, or a combination. It's something like in our theory about venous insufficiency from the brain. So a big question arises for Afterhead is why the same almost the same pathophysiology from the legs, it has not consequences to the brain. It's a challenge, it's a question, it's diagnostic challenging, I think. So another question it was, which is the method for screening, the best method, the ideal method for screening for CCSVI? Actually, there is a list of factors that would describe the ideal imaging study. This method has to have no risk for patient and low cost, high accuracy, and reproducibility, and of course easily accessible. Obviously, based on a recent review, there is no such device that can provide all these characteristics. On the other hand, double ultrasonography is in non-invasive, low-cost availability, and gives many information in real time about blood flow, phasicity, and function of the venous valves. You can see here a septum with stagnation of the blood. You can see here, which is something quite significant. There is no phasicity of the left internal jugular vein, and there is a normal phasicity on the other side. So we have to think about this and to consider much more than so far. Here you can see normal movements of the leaflets in the normal subject. Here is a very hypoplastic cusp, and here also septum and dilatation or aneurysm in one side of internal jugular vein. So, many discussions so far about criteria. Let's proceed to the first criteria. Bidirectional flow in one or both of internal jugular vein in both postures, or bidirectional flow in one position with absence of flow. The reflex time is considered pathological if it is more than 0.88. Is it correct? We're not sure yet. So we have to think about, we need prospective study. Reflex, how can define the term of reflex? What is reflex? We have, of course, to estimate the reflex time. For example, a reflex, I'm going to show you in a video later, reflex close to the leaflet for a short time is an absolutely physiological phenomenon. So, what about vertebral veins? Without colors, it's quite difficult to get images for the vertebral veins. Another issue which we have to think and we're still skeptical is the velocities. Here you can see you can see in the right in supine position, in the right vertebral vein, there are significant differences in the velocities. Very high here and very low here. Also the same on the other side. So it must be there a significant stenosis. So also always I think we have to measure and to estimate the velocities in all the parts, in all the length of the internal jugular vein and also the vertebral vein. What about intraluminal defects? You can see here, hypoplastic, also a very small movement, actually immobilized leaflet. We have to describe all these things. What about criterion 2? Because this is potentially an additional criterion, because not all authors have used the same transcranial approach, and because the QDP system, quality Doppler processing, is not available on all the equipment, the contribution of intracranial reflex is currently under debate. So it's not currently recommended, this criterion. Criterion number 4, internal jugular vein stenosis. Long discussion yesterday. Severe reduction of the cross-sectional area less than 0.3 centimeters square is considered pathological. Is it? We don't know yet. We're not sure. Something is wrong. Maybe. Okay. Another significant mistake which usually we do is this one. Here you can see a very small, in supine position, this is the common carotid, a very small cross-sectional area of the internal jugular vein. The same here, and the most common mistake is this. Usually we try to estimate, to evaluate the percentage of stenosis, compare the diameter here in this with the distal part of the internal jugular vein, using like an asset system, but this is absolutely wrong. So, criterion number 3, intraluminal defects such as webs, septum, or malformed valves combined with hemodynamic changes. For example, increased velocity, reflex, or bidirectional flow. And here you can see septum, very hypoplastic leaflets, and here, of course, you can see normal movement of the valve, of the leaflets of the valve. Another example. This leaflet is moved normally, but this is not. A significant reflex, you can see here more than 2 seconds. And to have an accurate estimation and more objective, we can use also the modality, like here, to estimate the mobility of the leaflets. Actually, in Athens, we are quite lucky because we work like a team. So in the same team, there is neurologist, radiologist, pathologist, and neuroradiologist. So it doesn't play. No, maybe something is wrong. Actually, it's a video. Criterion number 4, absence of flow. You can see here there is no flow in the in the left side in the internal jugular vein. Also here, and on the left side you can see some collaterals via the superior thyroid vein. Also here the same, and here we have tried in many. We start to try to estimate the volume flow in the internal jugular vein, and we get many measurements, at least 10 measurements in all the length, and we try to estimate the mean volume flow. So far, it seems that in healthy controls subjects, the mean volume flow is much more higher than in patients with MS. Criterion number 5. Long discussion yesterday also about cross-sectional area. We have to consider about this and maybe to think and to revise with much more, because we used almost, the term almost unchanged. So, this is a female, 35 years old, who has the luck to treat her problem by Dr. Sclafani. She underwent in 2 angioplasties in Athens, and the result was the total occlusion of the left side, and Dr. Sclafani put many stents on the right side to face the multiple stenosis. And you can see the result. It's amazing. You can see the stents. You can see the stents. There is a little bit, very small hyperplasia here without stenosis. The result is, as you can see, it's amazing. It's fantastic. And the same patient is here, and you can see on cross-sectional area the other side with total occlusion of the left internal jugular vein. Another case, also treated by Dr. Sclafani. So you get a conclusion, huh? Many patients from Athens come here. So you can see here, oops, sorry. You can see here significant residual stenosis. I follow these patients every month, and after the 3rd month, there was nothing. So there was something like remodeling. And in the same patients, Dr. Sclafani put a stent in the left renal vein, as you can see here, with a very, very good, fantastic results. So the patient, because as I said before, we have neurologists, the patients have fantastic improvement in clinical symptoms. So far, I think it's 3 months or 4 months after the procedure. So, an example, a very significant stenosis with rich collaterals after the balloon angioplasty, rich, the collaterals are not there. And another case here, and you can see here, this is amazing. It's a visual endoscopy. Maybe it's a promising method, and you can see also the thoracic duct inside, and by the end of this journey, let me say, you can see a significant stenosis of the internal jugular vein. So the conclusion, as Dr. Hage said yesterday, is that we have to combine the methods. We have to combine it, and to my opinion, I think, ultrasound in combination with MRV and with this sophisticated, really visual endoscopy maybe is the key for more successful diagnostic. And if we look a little bit upstairs, maybe we can get significant and much more accurate results. And this is another case with, this is visual endoscopy with MRV. And if we proceed, you can see an absolutely normal internal jugular vein. This is another case. And if we proceed a little bit deeper, you can see the structure here, which is maybe thoracic duct, or maybe vagus nerve, or maybe septum. So the number of patients we did so far is small, so we need much more patients to get some significant maybe results of this. Always we have to follow the same way to write down our reports. And of course, this is an example of reporting, and by the end, always we have to have a conclusion. So, in summary, combined transcranial and extracranial Doppler ultrasound allows us for non-invasive assessment of venous hemodynamic parameters indicative of CCSVI. These parameters are classified into, as I showed before, 5 criteria. For CCSVI evaluation, we need a high-end device, ultrasound device, and of course standard methodology and standard protocol. And of course training in application of duplex ultrasound CCSVI protocol is needed. Debate is still ongoing about CCSVI and its relationship with pathogenesis of MS. But these are the results from Professor Zivadinov, very significant. And in conclusion, I can say that clinical application for conventional and color Doppler sonography in pathologic venous processes have expanded recently substantially. No doubt, as experience with this diagnostic modality grows, use of this valuable non-invasive technology will become more universal and more accurate method for diagnosis of CCSVI. Thank you very much.
Questions?
I have a question. I have difficulty with the ultrasound after I've performed a large balloon high pressure angioplasty. I've stretched the valves. I expect to get reflux. Is there any evidence that shows what the values and the false negatives are, false positives for the CCSVI protocol ultrasound after angioplasty? Can I use it as a method of assessing progression of recurrence of disease? I'm really lost when I review them. I had a patient right before I came here who had 5 out of 5 criteria. The patient had an extensive treatment, and all signs and symptoms of multiple sclerosis resolved. No symptoms at all. He came back for a 6-month follow-up, still perfect, no problems, and had 4 criteria. I don't know how to use that information. I'm lost. So I would ask your group to approach as an area of investigation the clinical and the ultrasonic correlation after angioplasty at different times.
Absolutely agree. In our vascular department, I have two colleagues, and nobody knows that the patient has MS. They did first the examinations, following not exactly, about the same methodology, and we get different results. That's the problem with ultrasound. It's operator dependent. That's why we need very standards, criteria, and maybe new criteria. I don't know, new criteria. For example, cross-sectional area is something I don't know how useful it is. So we need to revise some criteria. We need to follow the same protocol.
Actually, as a corollary to that, one of the things that we actually discussed in our group was actually follow-up. There's about 30,000 people who've been out there who've been treated. And so with the MRI, we kind of came up and saying, 1 year after treatment, you should get a conventional MRI. But there was discussion from some of the IRs that were there as well saying, about 3 months after you've had treatment, then you should probably get an ultrasound to look for the bad things such as clot. And I'd be interested in knowing from both of you whether or not you would think that would be reasonable. And Sal, actually that would also provide you some of the information, like if you actually look at this criteria, what do you do with somebody who's doing well 3 months after? Because you would expect reflux after you stuck a big balloon in there and opened it up. So that was one of the things that we were actually hoping to get from ultrasound, as well as, does everyone think that a 3-month ultrasound follow-up would be reasonable?
I'm
Actually-
using 5 to 6 week, 6-week follow-up, thinking that the likelihood of thrombosis is going to occur earlier than late. I may be not correct, but we did save a vein because of that. It was asymptomatic thrombosis at 5 weeks. If you wait 3 months of thrombosis, the likelihood of restoring and salvaging that vein goes way down.
Actually, in the next room, we absolutely agree that the ultrasound is a screening method. Of course, it's not ethical to use catheter venography as screening method. It's an invasive method, facing with dangers to face allergic reactions. We use radiation and so things. So, but on the other hand, it's operator dependent, and we need criteria, maybe new. I don't know.
Karen?
Okay. First, Dr. Scalfani, to answer your question, in our research in our area, we do it at 1 month, 3 months, 6 months, with some asymptomatic. If they're symptomatic, obviously you do it sooner. We also discussed in our session that we are going to start, hopefully, have all the centers do volumes, do velocities, time average velocities. We are going to rework the worksheet. We've formed a committee to redo the worksheet so that all centers will hopefully use the same worksheet. So all data gathered is the same data, same area, same section. So this will help our multi-center. And also we discussed, right now some doctors are just doing the procedure without a pre-ultrasound, and then they send the patient to the ultrasound post. It's very hard to compare post. We'd like to insist that a patient have the ultrasound pre-procedure so it's easier to follow the patient post-procedure. So hopefully to make that a standard protocol.
Please go ahead.
Yeah, it's Dr. Hu from Taipei Veterans General Hospital. I just like to make it clear the flow, biphasic flow and the reverse flow is different. In ultrasound, yeah, the biphasic means turbulence, and the reflux is unidirection. So it's long ago we know if you do the ultrasound, check the valence valve, you will see the turbulence even in a normal patient. It's long ago we know it. So we check the reflux. We have to check above the venous valve, interjugular venous valve. You will see the unidirection, not the turbulence.
Absolutely agree. Reflexes, it means that we have blood flow in both directions, above the baseline and below. But we follow and get the Doppler for at least 60 seconds to get a video clip and to see during the 60 seconds which is the time reflex. In the opposite direction, that's what I mean.
The time direction is okay. We can define either longer than 0.5 seconds or longer than 80 or even longer than 1.6 seconds. Mm-hmm. Because usually if patient has a malfunctional valve, usually it lasts longer than 1 second. Yeah. It's usually, no matter your definition is to 0.5 or 0.8 or 1 second. That's not make no difference.
Sandy?
Just a comment on the follow-up. We've been doing follow-up in Barrie. We do it under an IRB protocol. The government of Ontario and the Minister of Health of Ontario has hired experts, and the experts in Ontario, the experts working for the government have decided that there's no need for any follow-up in Ontario. So there's significant discrepancy in terms of what the governing bodies are saying versus what this group is saying, and I think this group probably has the right approach that follow-up is essential, because the only way you're going to detect problems is to do follow-up. but we're meeting significant resistance from various arms of the government in trying to do any meaningful follow-up.
Okay, I think we must stop this discussion. I'd like to introduce Mrs. Kirsty Duncan with the next speech. We are short of time.
Yeah.
Sorry.
While she sets, please come up. While she sets up one more question. Go ahead, fire away.
I have a comment about follow-up. I was with a group of 15 people who went to see Dr. Kostecki in, I forget the name of the place, in Poland. And there were 3 people who were stented, and each of them, he checked the next day for thrombosis. And fortunately, they didn't have it, but I've seen other cases where they get thrombosed the next day. And I can show you, film. And, it was only by insisting that this thing be looked at that it was discovered. So I don't think 5 weeks is enough. I don't think 1 week is enough. I think you need to check like the next day because you send people home.
Yeah, I think we, one comment about carotid stenting, for instance, carotid stenting. We do the Doppler the day after the procedure.
Yeah. Right.
That's standard protocol for carotid endarterectomy, carotid stenting. Sure. Why should this be any different?
We do the same also.
Okay.
Dr. Sclafani, the next day.
People,
And it depends, the thrombosis, it depends of the medicine which you give after the stenting.
right. Well,
So far, the Plavix was quite disappointed us. Huh?
right. Well, the last one I saw was
Sorry,
Credoxa.
we are running out of time.
Oh, that's bright. It's very bright. Good morning, everyone. Can you hear me okay? We're good. It's a real honor and privilege to be here. And I think many of you know I come to these meetings in order to learn the latest science, in order to take the information back to Canada, to fight for those living with MS in Canada. What you may not know is I am a former health professor and a former research scientist. I've really enjoyed the discussions this morning. This talk is going to be a bit different, and it's really going to be about a research agenda focused on care. I guess the first thing I'd like to ask are, what are the goals for care of people with MS and prevention of MS in the next generation? We hear from one of the major advocacy groups, it's to help patients live with the disease. I think that's personally outrageous. Is it to provide patient-centered care with the choice of treatment? In Canada, people who pull out of drug trials are threatened with the removal of their driver's license. Is the goal to improve quality of life? Is it to prevent progression of disease? I'm just going to raise a lot of questions with you. What, if any, frameworks exist regarding early symptoms of MS? How can these be relayed to medical students and to general practitioners so MS is picked up at the earliest stage possible? And what, if any, monitoring takes place in families with a history of MS? What is the medical profession's current understanding of a person's experience with the disease? To what extent are people with MS consulted regarding how they can be better served by the medical profession? What challenges have they faced in dealing with it? And how can these be overcome? What are they consulted about their disease so people can better understand their symptoms? When I first went to that first conference in McMaster, and I talked to many neurologists, and they said, this is a ridiculous theory. I said, have you ever felt the temperature of a hand of someone with MS? Have you ever felt their arm? Have you looked at the colors of the hands, the colors of the palms? What do their feet look like? What are the changes they see in their bodies years before diagnosis, and the changes that take place in the intervening years? What do they think about the medical profession's understanding of their disease? Do they think there are symptoms that are being overlooked? Have you ever asked them about their pain? We just generally hear they're in pain. Is it nerve pain? Is it constrictive pain? Do they feel like something's been put around their neck? Where is the pain if they have pain in the neck? Where is the pain in the chest? And what steps do they take to manage their disease? And what do they find is effective and what is not? Perhaps we need a better understanding of their disease. And I would suggest perhaps working groups of medical doctors or scientists with MS. You're going to have to make it okay for them to come forward because of the stigma associated with the disease. In Canada, I've had 20 medical doctors write to me. Their colleagues don't know they have MS. And they say, please keep fighting for clinical trials for CCSVI. It works. But they're too afraid to come forward. What about high-performance athletes who know their bodies extremely well and recognize changes, perhaps decades, when you talk to them before the disease is ever picked up? These are tough questions. Who's asking the questions to actually improve quality of life for people with MS? Is it the physician? Well, in Canada, if you have MS, most doctors, or not most, some doctors don't want to treat you. These are people with complicated symptoms. And what is the average length of that appointment? Is it the neurologist or the MS specialist? What does that exam actually include? Does it include testing of symptoms people actually experience? Is it the interventional radiologist? What is done beyond diagnosis and the procedure, and we are grateful that you do the procedure. People can't get it in Canada. What follow-up is done? What changes are being recorded? How is it being determined if that procedure is making a difference? And what is currently being done to bridge the polarization that exists between various factions of the medical community, and to prevent those who live with MS from falling through the cracks? And remember, this discussion and this polarization occurred in the 1980s between vascular folks and the neurologists, and we can't allow it to continue. What recommendations are actually being made to improve quality of life? Is the medical profession asking the right questions about MS? What health problems were ever diagnosed before MS? Do they have arthritis? Now, in talking to 1,500 Canadians and 1,000 around the world, you start to see themes: arthritis, digestive problems, eye, sinus problems, headache, thyroid problems. What is the cranial, facial, and neck anatomy? Are there things you can pick up? Is there a styloid process impinging on a jugular vein? Anything else? What dental problems? When you talk to MS patients, they have profound dental problems. Unusual acidity, unusual plaque buildup, cavities. People describe as having a cavity that goes from 1 tooth through 4 teeth, inability to freeze their mouths. What type of pain can they distinguish? Does changing position, experiencing weather changes, flying, going up the stairs, cause difficulties? And if so, explain. If you talk to many MS patients, flying can be agony, and many will describe that they are human barometers. Are lesions a good measure of disease status, or should we be looking at perfusion, vasculature, or something else? How well do neurological tests pick up the early course of the disease, particularly in someone who was an elite athlete? How often do you hear the story that someone's complained for 10 years of these changes that are taking place in their body? They go to a neurologist every year, and the neurologist says they're fine. What are the best scales to measure a person's quality of life? And how do medications or procedures affect quality of life? And when you talk to patients, what specific actions relieve their symptoms? What changes do they notice? And how long do they last? And I think it's time that we talk about what are the best combined therapies for CCSVI. Is it CCSVI plus pharmacological agents? Are there pharmacological agents that could be used to treat hydrocephaly, venous inflammation, iron storage? Can this be added to CCSVI treatment? What safe apparatus can be used to keep veins open? Are vein grafts possible? Can stem cells be added to this? Should stem cells be added to this? What about trying to normalize CSF flow? I'm just throwing these questions out there. And what should follow-up care look like for CCSVI treatment? What is the optimal environment for recovery? What is the impact of air travel? And you have changes in oxygen and pressure on someone who's newly treated. What are the best supportive care therapies? Brain plasticity exercises, drugs, nutrition, osteopathy. Osteopathy is it's a therapy based on blood flow and nerves. Physiotherapy, speech therapy. We've got to start talking about how we get the best results in people living with MS. And, you know, is there something you can do with dental apparati that might change pressure and flow and sutures? And how do we look at prevention of CCSVI in the next generation? For those living with MS, one of their greatest fears is about their children. Do vascular issues, do they develop in utero, childhood, later? What's the best methods to discover circulation problems at the earliest time possible to avoid health impacts later? Are there marks that might give an indication that there's a vascular problem? How many of you have ever asked those with MS about vascular birthmarks? Or a birthmark, they call them a birthmark, they actually appeared in the few weeks after birth. Will giving vitamin D to pregnant moms help? Do giving antioxidants, vitamin D, omega-3, reduce vein inflammation? Will giving this to children and adolescents reduce the risk of developing vein inflammation, venous hypertension? I don't know. I'm throwing them out there. What's the optimum time to undertake CCSVI screening and treatment to avoid health impacts at a later date? And I guess in closing, I'd like to call for an interdisciplinary conference with various sectors of the medical profession. We've got to bring these various groups together. The IRs, the neurologists, the nutritionists, the physiotherapists, and let's look at developing patient-centered care for MS, bridging the gaps so that no one falls through the cracks, better learning the patient's experience with the disease, better supporting their needs, and developing methods that measure improvements in quality of life, and then providing educational materials of new science. And really a call that we have to go from working in silos to interdisciplinary, multidisciplinary, and a focus on patient care. And with that, I will say thank you, and I will profoundly say thank you for the tremendous work that you all do. Thank you.
Excellent. I think because of constraints in time, it would be great if you could proceed directly with Jack Burks, talking about bringing neurologists into the CCSVI,
I'm a neurologist, and I'd like to thank Mark Hakey and the other meeting planners for inviting me to express my opinion of what I'm hearing from the neurologic community. And not all the neurologists share this opinion, but I'm giving you an overview of what I think they're thinking about CCSVI, and I think it might help you as we try to work together in the future. I'm also pleased that I survived yesterday's talk to patients. Anyway, I must say I was impressed with what I've heard this morning. That you're taking a critical look at the issues yourselves. You're fussing back and forth. That's exactly what's going to bring neurologists to the table, because we want to look at all the issues. We don't want to say, well, we obviously have the answers to everything. We don't have the answers. And I think neurologists can help with getting some of these answers. And your openness to criticize your own work and to look for a better way was very gratifying for me. Now I'm going to, where's the, okay, so what do neurologists need to support any, not only CCSVI, anything that comes as a possible a theory? Well, they need a plausible theory, an hypothesis that take into account what we already know, not something different necessarily, unless it's a different, whole different approach, or is it complementary to what we already know. We need a definitive diagnostic test, and that discussion has already happened today. We need scientifically designed outcomes and trials done by people that know what they're doing, and that the design should meet FDA and neurology standards. And so I think it's good to know what the neurology standards are. And then we need follow-up. Is this a sustained effect? What are the side effects, the adverse events? Those are the things that you've been talking about this morning, and neurologists will be pleased to hear. Some of the questions, and you've heard these questions, you've asked it yourself. Does it exist? Dr. Zavadanoff is going to talk about that during this meeting. Is it a normal variant? Is it clinically relevant? Does it cause MS, or is it a consequence of MS? Okay, so we've got this treatment. Let's define, is the angioplasty considered by you a disease-modifying therapy, a symptomatic management therapy, a quality of life therapy, or a combination of those? And how are you trying to distinguish that? Is it possible that it could be disease-modifying? Is that the theory? Maybe an early disease, but a symptomatic management later in disease? We need to be more definitive about that so the neurologists will understand what we're really talking about. I'm not going to talk about placebo effect because we've talked about it a lot, but neurologists are well aware of this in multiple sclerosis trials. And basically, one-third basically have no effect, one-third maybe a little better, and one-third are a lot better, but we're not sure for how long. And we're trying to distinguish uncontrolled data, saying, well, how does that fit into our experience with placebos? And it may be that a positive outcome might show that CCSVI is an additive influence on the treatment. And it may end up being an adjunct treatment to disease-modifying therapies. But you have to decide as a group, is this a monotherapy or is this a combination therapy? What role does CCSVI have versus the disease-modifying therapies, et cetera? Those are issues that we need to come to the table to discuss. And stop throwing accusations without even meeting each other. Let's look at it over a table discussing it, and I'm going to talk about that later. Okay, so if the claim is it's a disease-modifying therapy, these are some of the issues that would be faced. You define the outcomes before the trial. You don't get the results and then look at it post hoc and say, oh, well, this looked interesting, let's report that. No, it should be done before the trial. We need to make certain these patients have the right diagnosis, because many of the patients that are being treated are never referred by a neurologist with why the patients have diagnosis. And I can tell you there's a lot of people around with the diagnosis of MS that don't have MS, but who think they have it. So you have to be careful about that. It's a reason for working together. That any trial must have a documented diagnosis, it must have controls, it must have randomization and blinding. That's what neurologists expect out of any treatment. And DMTs, okay, we want to decrease disability, decrease MRI lesions, decrease relapses, and we want rigorous statistical analysis. And I think that there ought to be somebody looking at all these studies and saying, what is the statistical method? Is it a legitimate statistical method? Because you can have a tiny bit of difference that if you look at it as a one-tailed test, it could be statistically significant, but as a two-tailed test, it wouldn't be. Those are sort of things that neurologists look at. Obviously, we have to look at safety issues and sustained effect. We don't think endovascular people know what a pseudo-exacerbation is. So when they're out there measuring exacerbations, and there are pseudo-exacerbations, which are probably half the exacerbations, they're not really exacerbations. There are people who have an emotional problem and they feel bad for a few days, or they have a urinary tract infection, and instead of treating with steroids for an exacerbation, you treat the urinary tract infection first, and all of a sudden the patients are better. We need to look at that. And you can't take the patient's word for an exacerbation. Exacerbation is defined as an objective, a neurologic difference, a change in the EDS that's objective. It's not a patient-reported outcome. And they're the add-ons. Okay, so what if we say it's a quality of life issue? Okay, what would you want to measure if it's quality of life? People say, well, you just can't. You can't really quantify symptoms. You can't really quantify quality of life issues. You just ask the patients how they're doing, and that'll be symptoms and quality of life. It's not true. There are validized, standardized testing for many symptom management, and I would encourage you to work with your neurologist to see what those are, because there are ways to manage. There are ways to work with symptom management, and so there are scales for walking. There are bladder indicators that are objective. Also, patient-reported outcomes are important, but there are ways to measure this. All right, what about quality of life? There are quality of life scales. You've seen some of those, and caregiver observations, I think, are another important aspect. So other variables. What we say, okay, well, we say we help people with CCSVI feeling better, but how much? Is it 10%? Is it 25%? Is it 50%? Put those in your calculations. Make sure you separate good days and bad days. Do you know that? I mean, MS patients, some patients can throw their cane away for a day and have a good day, and the next day they're wishing they had a wheelchair. They have good days and bad days. That's normal fluctuation. Even people have difference in morning and afternoon symptoms. So therefore, people tend to do better in the morning, and they do worse in the afternoon. So if you're examining patients before you do the procedure in the morning and after you do the procedure in the afternoon, you'll find different results. And we also have to look at societal outcomes. So why are so many neurologists resistant? Well, why not give it a try? I think that's important. I'm going to spend the last little bit talking about that. I think neurologists now would say, I'm not resistant. All you have to do is show me that the treatment is believable, and that, and you've done a risk versus benefit analysis, and you've looked at the cost of this and made it shown it's cost effective. As soon as you show me that, I'm with you guys. But right now, the pilot data was uncontrolled, randomized, non-binary. You all know that, but it was presented to patients as convincing data. And you know what neurologists said? Oh, God, those cowboys are at it again. Does that sound familiar? You've had that before in other breakthroughs that you've done. There are now standard operating procedures in the world of medicine. But then what happened is the media started promoting this as a liberation procedure. So now the neurologists had to deal with liberating from what? Liberating from FANS or liberating from MS or whatever. And then the social media took over. The phenomena of the social media was unbelievable. The power of the social media was incredible. Well, what happened is the neurologists became infuriated because now they felt that the patients would be subjected to this speculative theory that's very expensive, maybe dangerous, and certainly unproven. And then they go to the internet. Have you been on the internet? Look up at CCSVI on the internet, guys. Medical tourism is rampant. very expensive. People go to these places and they get anticoagulants, they get the procedure, they're sent back, there's no follow-up, there's no records being sent to the doctors beforehand or after. It's not something neurologists want to have any part of. And so what happened? Most neurologists retreated. They said, show me the data. Okay, that's a fair enough statement. I don't want to be involved until you show me the data. And I'm not going to participate in trials. So I'm going to ignore it. And maybe it'll go away like snake venom and bee stings. And so I'm not going to get that involved in this study. And it's a no-win situation. Because, okay, on the one hand, the neurologists are saying, I'm not going to believe any study I didn't participate in. And I'm not going to participate in any of the studies because it's not going to work. And if I participate in the studies, I'll be ostracized by my colleagues who feel worse about CCSVI than I do. And then I'll be accused of becoming one of those guys, one of the cowboys. So I don't want to get involved in this. I just want to stay away. Well, I think the situation has changed. I think we have more data. I think neurologists are going to be more interested in working with you, and so we have an opportunity. It's going to require all of us working together. We've got to integrate the neurologic aspects and the interventional aspects. And so I think the next step is putting a vested group together. And Christy mentioned this. She's absolutely right. Let's bring the healthcare professionals, the patient groups, the research design people, all together around the table to discuss the issue. And I'm going to talk about a specific plan on Wednesday, which I think would be helpful. We've used this before. Neurologists are familiar with it. It's been helpful. And I think we can bring neurologists to the table. Thank you very much.